Hi, everyone. Welcome back. What a great day of learning we've had so far. Thank you all so much for your active participation. You all have had some great questions, and Patty and Michael and Jolie, they've just been phenomenal. I know I have learned so much this morning. Hopefully, you all were able to take a quick break, maybe grab some lunch, and now you're getting settled back in for our very special keynote presentation. Before introducing our speaker, however, I would like to once again thank our financial sponsor, the Weldon F. Osborne Foundation, and thank you also to the University of Tennessee at Chattanooga School of Nursing for their partnership and help with planning this event. At this time, I would like to introduce Dr. Rewa Thompson. Dr. Thompson is a women's health nurse in Greater New York and a clinical assistant professor at Stony Brook University. She received her Bachelor of Science with a major in nursing from Adelphi University, a Master of Science in Women's Health Nurse Practitioner certificate, and Doctorate of Nursing degrees, also from Stony Brook. Dr. Thompson has been a devoted women's health expert for the past 25 years. Her clinical scholarship is deeply rooted in population health matters that encompass disparate outcomes in maternal mortality, diversity and inclusion in healthcare, and nursing education. She supports advocacy for reproductive health rights, social justice issues, comprehensive access to contraception, health literacy, and sexually transmitted infection prevention. Dr. Thompson is a passionate nurse educator that believes in promoting self efficacy and student empowerment. She's a strong proponent for teaching and mentoring competent and caring nurses. She's dedicated to fostering relationships with undergraduate nursing students to develop their clinical excellence skills by providing a variety of innovative teaching strategies to enhance their learning. Dr. Thompson supports the effort to address the nationwide nursing faculty shortage by encouraging baccalaureate prepared nurses to pursue advanced practice degrees in nursing education. She's also a faculty mentor and preceptor for graduate nursing students actively seeking master's and doctoral degrees. So it is truly a privilege to welcome Dr. Rewa Thompson to our virtual stage. Dr. Thompson?
Thank you so much. Good afternoon, everyone. Thank you, Susan, for such a gracious introduction. I am excited to be invited to deliver the keynote presentation today on implementing contraceptive equality into your practice. Next click, please. So today I'd like to start out a little different by sharing this video. And I'd just like us all to watch the first 2 minutes of this video together and sort of just take some mental notes about the interaction you see. So please press play.
Baby. We can go over all of this in more detail, and you can tell your fiance that we provide the best in maternity care. Now visibly hurt and uncomfortable, Noelle says, "I'm here to learn about options for preventing pregnancy." You apologize.
I'm so sorry. It seems as though we could not hear the sound, so I'm going to start the video over, and that was because I was on mute. So my apologies. Let me just
Okay,
start this
no
over
worries.
really quick.
Welcome to Clinical Minute. Noelle is a 30-year-old woman presenting for a contraceptive consult. Based on the information from the standard intake form, you know that Noelle's sex is female, and her last pap test from 2 years ago was negative. She presented for STI screening approximately 1 year ago, and her last normal menstrual period was 14 days ago. When you enter the room, you see a woman of color wearing a hijab. After scanning the intake form, you assume that the medical assistant meant to write preconception counseling instead of contraceptive counseling. You wonder if Noelle's husband will be entering the room shortly. You say, "I see you are here for preconception counseling. Would you like to wait for your husband before we begin?" Noelle looks confused. She says, "Husband? No, I am not married." You follow up by asking, "Your fiance then? I see that you're here to discuss planning a family. Since you are 30 years old, we don't have to worry about your age abnormalities. There is an increased risk for gestational diabetes, however, based on your weight. This can impact your health and the health of your baby. We can go over all of this in more detail, and you can tell your fiance that we provide the best in maternity care." Now visibly hurt and uncomfortable, Noelle says, "I'm here to learn about options for preventing pregnancy." You apologize and attempt to move on by asking about her previous experiences with birth control. Noelle responds briefly, "The pill." You ask her how satisfied she was with that method, and she says it was fine. You offer to renew her prescription or to provide information on other options, and Noelle says, "Just the prescription, please." You write the prescription and ask if she has any additional questions or concerns she would like to discuss today, and she quickly says no. Noelle leaves with a prescription shortly thereafter. What went wrong in this clinic visit?
So, as you take a few minutes to think about, or maybe even jot down what you believe went wrong with this visit with Noelle and the provider, I'd like to take a look at how healthcare in this country has been delivered and how it may have contributed to the provider arriving at her assumptions during this visit. Next click, please. So, the history of healthcare in this country, first we should take a look back at what are healthcare disparities. And the history of healthcare disparities, basic definition of a disparity is a population as one in which there is a significant disparity in the overall rate of disease, incidence, prevalence, morbidity, or mortality in a specified population as compared to that of a general population. And one of the first things that comes to mind when we think of healthcare disparity is racial discrimination. So we know that racial discrimination exists in society today and has a negative impact on healthcare and patient outcomes. Racial bias is the fundamental cause of inequities in health, and it creates barriers that persist even in the absence of interpersonal racism. Another part of that disparity comes with structural racism. So, structural racism encompasses public policies and other institutional practices that produce and perpetuate racial inequities. This specifically refers to the totality of ways in which society will foster discrimination through mutually reinforcing inequitable systems of housing, our education, employment, opportunities, earned income, benefits, credit, media, healthcare, and of course, our criminal justice system. So, with all these healthcare disparities, another impact that may affect this, you could click next, please, is implicit biases. Implicit biases are unconscious attitudes that can influence affect, behavior, and cognitive processes. Such biases impact the patient and healthcare provider interactions. It can also affect how patients are treated, what type of decisions we may make, or at a patient's adherence to a treatment plan, which in fact will affect patient outcomes. And just watching the first 2 minutes of the video, we suspect that the provider may have had implicit or even an explicit bias because she had certain thoughts or she came to certain conclusions about her patient and actually verbally expressed it. Next slide, please. So, what contributes to healthcare disparities? There's so many different thoughts of what contributes to healthcare disparities in this country. But the first thing that we know contributes to it is race and ethnicity. Race and ethnicity is a social construct that can provide useful information about cultural, behavioral, and medical factors that affect a patient's health. So, for example, a medical factor is that we see increased frequency of genetic diseases like sickle cell anemia in individuals of African descent. But there are studies that suggest that the effect of the experience of racism and life stressors can also impact our health outcomes and behaviors, and that other factors like our dietary choices or our physical activity may also vary by race and ethnicity and actually impact those differences or contribute to them. Next click. Another factor there is a religion. Religion also affects our health outcomes basically because of what your fundamental beliefs are. You may have a belief that would preclude you from adhering to a recommended treatment plan like prenatal genetic screening. We also know different religious groups. Some Muslim women may be affected or adversely affected with healthcare because they may have to delay seeking care if they don't have a female provider within their reach. There's some faiths that even may restrict women from using contraception. And as we saw in the video, Noelle, the patient, had a hijab on. So just the fact that the provider walked into the room and saw her in a hijab, she started to make assumptions about what type of care she would receive. Next click, please. Gender is also affected. We see disparities just based on gender oppression and what societal norms are. We see transgender patients being affected because in some places they're not considered their own gender, or they may not feel welcome, so they may delay health care or any type of care, contraceptive care or general health care, because they may feel discriminated against. Sometimes the media also may adversely portray women who are menopausal. And sometimes that can affect the type of health care. Also, age. Depending on the age group, we know adolescents in our contraceptive health age group may have a tendency to be more risk takers. They may not be reliable. They may not be dependable or adhere to a treatment plan. Next one. Sexual orientation. We shouldn't assume that all our patients are heterosexual. You may not have seen the rest of this video for time constraints, but as you go on in the video, Noelle actually discloses that she's queer. She identifies as queer. She's bisexual. So making the assumption that Noelle was coming to plan a pregnancy because she's a Muslim woman was wrong, clearly wrong on the part of the healthcare provider. Making assumptions at the beginning just breaks down the communication for or the establishment of a relationship from the beginning of the visit. Next. Socioeconomic status is a big factor. In our country, our health system is driven by market forces and contributes to poor access for citizens who are uninsured or underinsured. Minority women are disproportionately of low socioeconomic status and therefore are more adversely affected by states that may not expand Medicaid coverage. This is an example of the structural inequities that persist and permeate in our society. This also encompasses unequal educational opportunities, which may lead to lower income jobs, which with a lower income job, there may be less likely to have insurance coverage or very minimal or limited insurance coverage. Also, varying geographic availability of healthcare institutions, lack of transportation and money for transportation also increases the barriers to access. So next slide, please. So how do we as providers contribute to the impact of implicit bias in our care of our patients? We are generally expected to view our patients objectively and impartially, but sometimes that doesn't always happen based on what our unconscious biases or our perceived biases are. So I researched, there's a plethora of literature articles about bias. The first article you see on your left is from 2004, and it really encompasses the same problems that we see now over 15 years later. The first article talks about stereotyping and bias is not just an individual product of the provider, but it can also be caused by features of our healthcare setting that decrease our cognitive capacity. For example, fatigue or overload with time constraints with patients. So they found in this article that the conditions were more prevalent in settings that predominantly see minority patients. The second article in the middle was published in 2020, and it reviewed the historical backdrop of state-sanctioned eugenics programs to control the reproduction of women deemed unfit to parent and valued other women's fertility over another woman's fertility. So an it's just an example of structural racism and sexism. Some examples are women who were imprisoned were offered to have LARCs, were offered to have reduced sentences if they used a LARC method. So the history of coercive policies tend to continue to shape our biases that influence our perceptions and actions. Overall, this level of thinking really contributes to poor communication and poor satisfaction of minority patients. The last article on your right was published in 2016, and it was a qualitative study of 50 women aged 18 to 29 in Wisconsin. And what they did was they documented these women's perceptions of LARC-related provider influence. And women reported that their preferences regarding contraception selection or removal were not actually honored. The participants in the study, the majority of the participants in the study, believed that providers recommended LARCs disproportionately in socially marginalized women. And I would just speak to that. In my family planning facility, we have situations where we have some patients that are insured, we have patients that are not insured, and we carry the progestin only LARCs, and we carry the copper IUD. And if a patient has insurance, there's a tendency to give them more options because their insurance will cover the insertion. If a patient has to pay out of pocket, and I myself have been guilty of that, I would offer them the LARC that I knew that was most affordable. So what I realized was I was contributing to the problem by not giving the patients the right to know everything that was available to them and then let them make the choice. Some women may actually not mind spending more than she had for the quote unquote better LARC device than just taking a cheaper one because she didn't have insurance. Next slide, please. So with that being said, how do we as providers help to ensure contraceptive equality for all patients? And I'd like to call these a mnemonic I created for myself called the 3 E's. And the first one I started out with was the encounter. So the encounter is very important because that is when you are entering the room and you are creating that patient-provider relationship. And at that first encounter is where you will develop a relationship of trust. We want our patients to trust that what we're telling them is for their benefit. So we think back to the video about how that provider made assumptions about Noelle prior to entering the room, and then she continued to allow her explicit biases lead to her patient feeling uncomfortable, and then it created more of a communication barrier. Next click. I recommend taking the implicit bias test at this particular website because it can further help you identify how unconscious thoughts affect conscious behavior. Next click. With the encounter, with establishing trust, you must be able to effectively communicate with your patient. Open-ended communication means you're not asking questions just to get through the visit. You want to hear what the patient has to say. You want to have the appropriate body language and the right eye contact to connect with your patient, establish trust, show that you care what the patient is telling you. And I understand from a provider perspective that sometimes that waiting room is full and you're working by yourself and there's so many other things going on. But there's still a way, even if you only have 10 minutes, there is still a way to make your patient feel like you care, that you are there to advocate for them. Another thing to have also is gender inclusive intake forms if you don't already have them in your place, and know how does your patient want to be identified, so you have an idea when you walk in the room. And my medical assistants, they do intake forms. I read them, but when I go in the room, I still review with the patient because there may have been something that was missed, and I don't want to make any assumptions. The second E I'd like to call empowerment. Empower is by creating this trusting relationship with your patient, you are actually empowering her even more. Now you have full disclosure from her. She's likely to be more comfortable and she'll be honest with you about her health. Because I know it's had to have happened to you where they come in and they tell the assistant A, B, and C, but then when you are in the room with them, depending on how they connect with you, all of a sudden the story is different. The reason why they're there, there's so much more information. So even though it may just be a contraceptive visit, you are still getting so much more out of her that can help you come up with the best decision making process for her. So it really, you're also listening to her free of judgment, not making any assumptions, not interrupting her, so she can see you're there to help her and not harm her. And the last one, the last E, I'd like to call education. Listen first to what your patient is interested in and see if she's medically eligible to receive it. Then allow full disclosure of her choice. Some patients are, they have no idea what they want. So we don't want to have provider fatigue where it's the end of the night and this is your fifth woman of color that's come in and you're just going to assume, well, she's had 5 children. Let me just insert an IUD. Let me just put in an Explanon. Let's go over her history, see what she wants. She may actually want pills. She may be afraid of a LARC method. So giving her the chance to be informed of all her methods. And some of you may be in places where you have an educator that will give them their options first. And we're making a decision that's best for them based on a mutual agreement, what they're really medically eligible to use. So really the education really helps to embolden and empower your patients even more so that they can really feel like you gave them every option, you gave them a chance, no matter how they looked, no matter how they dressed, no matter what their socioeconomic status was. They really want to feel like they have been given a fair chance, just like any other woman. So implementing contraceptive equality into your practice actually means that all your patients that you see can make their own choices about their contraception and that their healthcare provider can respectfully help them navigate their decision-making process without any bias. If their healthcare coverage or their lack of coverage precludes them from using a method, you will work as a health provider to help discover ways so that they can receive full access. Thank you for your time today.
Thank you so much, Dr. Thompson. It was wonderful to have you today. Thank
Thank
you.
you very much.
To all of our attendees, up next, we're going to have a little R.E.A.C.H bingo break with the staff of A Step Ahead Chattanooga. So I hope that you will go over to the Sessions tab on the left-hand side of your screen and join our health educators for a few minutes of R.E.A.C.H bingo. Thank you so much.